Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, I'm Dr. Bill Gradisher, Professor of Oncology and the Betsy Bramson Professor of Breast Oncology at the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. And I want to welcome you to this educational activity entitled Clinical Cases in Hormone Receptor Positive, HER2-Negative Early Stage Breast Cancer, Applying the Latest Evidence. Joining me to work on this activity are two colleagues who are well-versed in this topic, Dr. Aditi Abardia, Professor of Medicine, Director of Breast Oncology Program, and Assistant Chief of the Division of Medical Oncology and Director of Translational Research Integration at the UCLA Comprehensive Cancer Center, and also Dr. Seth Wander, Assistant Professor of Medicine at Harvard Medical School and a faculty member at Massachusetts General Hospital. So as we get into the topic, we can sort of broadly think about how we approach patients with hormone receptor positive disease and how we make decisions regarding adjuvant therapy. And to a large degree, this is based on an assessment of a number of different clinical features as well as pathologic features that we try to integrate into our minds and basically get a gestalt for how high the risk is that the patient may have a problem in the future, which in turn translates into many of the treatment recommendations we make. So with that said, the things that we commonly think of that are very relevant to those decisions include whether the patient has low-grade disease or high-grade disease, whether the lymph nodes are involved or not, and if so, how many, whether they have had a molecular test that helps us determine whether or not only what their prognosis might be, but also in many cases, whether the addition of chemotherapy may further reduce the risk of recurrence. We look at proliferation in the form of Ki67. Not all centers do this, but many do. And what this helps us understand is how aggressive the tumor is based on how rapidly or what fraction of cells are proliferating or dividing. And then, of course, tumor size, not unlike nodal burden, gives us a sense of the volume of disease and can also guide our recommendations. Other factors that are relevant are whether the patient is pre or postmenopausal, and this has some bearing. Obviously, if you're dealing with premenopausal patients and you're trying to optimize their endocrine therapy, particularly if they're high risk, you may consider ovarian suppression. Or if you're tending to want to use an aromatase inhibitor in a patient, if they're pre or perimenopausal, obviously you have to take in their ovarian function into account. If a patient has received preoperative therapy and they undergo surgery and they're found to have significant residual disease or not, that can also influence your considerations for adjuvant therapy. There are a number of things that, at least at the present time, we don't view as highly relevant, although from clinical translational standpoints, they do have some importance. The histology of a tumor. Most breast cancers are either ductal or lobular. Does that necessarily influence the type of therapy we offer a patient, particularly as it relates to endocrine therapy? No. Tumor infiltrating lymphocytes is a hot topic, but at the present time, it doesn't really guide our therapy. Hormone receptor expression is important. Certainly if somebody has very low hormone receptor expression, the probability of benefiting from endocrine therapy is lower than if you have high, but any level of hormone receptor expression is likely to prompt you to use endocrine therapy. And then finally, whether a patient has a BRCA mutation or not isn't going to necessarily dictate the type of endocrine therapy you give to a patient if they're ER positive. However, it may influence whether you use certain PARP inhibitors. So if we sort of distill all that information that I just sort of broadly discussed a moment ago and put it into table form, you can sort of categorize patients into those that fall into higher or lower risk, sort of a gradation of risk, and thereby assign certain therapeutic interventions that may be most appropriate. So in patients that have low risk disease based on smaller tumor size, uninvolved nodes, very high hormone expression, low grade, etc., these are patients who may be most appropriate for endocrine therapy alone. Whereas patients who start to accumulate other features that make them seem more aggressive, bigger tumor, nodal status, lower levels of hormone expression, higher grade disease, proliferative index going up rather than being low. These are patients where there is some consideration for adding to endocrine therapy, and that could include a CDK4/6 inhibitor, which we'll talk about. Additionally, these patients may undergo genomic testing or molecular testing that would indicate they may benefit from chemotherapy. And then finally, for patients at high risk, where they have all the features that you would think of as being less positive, big tumors, many nodes positive, relatively low or absent hormone expression, higher grade disease, high proliferation, etc. These are patients where you want to do everything you can to reduce risk. And if they have any level of estrogen receptor expression, you will use endocrine therapy plus a CDK4/6 inhibitor. And in most cases, these are the patients where you're going to use chemotherapy. So what are the role of CDK4/6 inhibitors in early breast cancer? They've all been evaluated in the adjuvant setting. And the most compelling data for their use is really with both abemaciclib and ribociclib. So in the monarchE trial, these were patients with node-positive disease, including micrometastatic disease. And these could have been patients from stage 1 to stage 3. And these are patients who would have gone on to receive endocrine therapy with the CDK4/6 inhibitor, in this case, abemaciclib, for 2 years. Now, in the NATALEE trial, these are patients who would receive ribociclib if they had certain high-risk features. The NATALEE trial was more inclusive, with the inclusion of patients with node-negative disease being eligible to participate in the trial if they had certain high-risk features. And the duration of ribociclib in that trial was 3 years. The NCCN guidelines, as well as other guidelines, have incorporated these recommendations into their guidance for clinicians. So both of these are category 1 evidence and preferred regimens. So as I already mentioned, with respect to monarchE, it includes 2 years of abemaciclib in combination with endocrine therapy for patients who are high risk, more than 4 nodes involved, or 1 to 3 nodes with other features, either grade 3 disease or a tumor greater than 5 centimeters in preoperative imaging or even at surgery, whereas ribociclib is recommended for 3 years with an AI. And this could be patients with any lymph node involvement, even microscopic. And as I mentioned a moment ago, even without nodal involvement, if the tumor is greater than 5 centimeters or 2 to 5 centimeters, but additional features, including grade 2 or a high genomic risk based on a molecular test, or high proliferation based on Ki67 or grade 3 disease. So we have a couple of options for these high-risk patients. And what has the data shown us so far? Well, in both cases, the trials have demonstrated that the addition of a CDK4/6 inhibitor improves outcome. And if you look at the primary endpoint of these studies, invasive disease-free survival, monarchE with longer follow-up shows about a 7 to 8% improvement with the addition of abemaciclib. And that has been a continued effect even with longer follow-up. In fact, the benefit seems to be growing a little bit. We see the same phenomena that with the addition of ribociclib, you get about a 5% improvement in fewer patients experiencing recurrences who receive ribociclib. So a clear indication that you are impacting on the course of this disease. The survival in both of these trials is immature at this point, but there is at least a trend, if you look closely, suggesting that there may be a survival benefit that does emerge with the addition of either ribo or abemaciclib in these trials, but we're not quite there yet with respect to the data. So I think what one can surmise from that short discussion is that with more treatment options now approved for early hormone receptor positive breast cancer, we have to think about how we define the patients at the greatest risk of recurrence and how can we prevent or at least delay those recurrences from developing. So we are going to discuss how we tailor adjuvant therapy for patients with hormone receptor positive, HER2 negative early breast cancer who have low, borderline, and high risk of recurrence, and apply the latest evidence to optimize the treatment for these patients. So please continue on to case one, in which we illustrate a patient with hormone receptor positive, HER2 negative disease at low risk for recurrence, which will be discussed by Dr. Bardia.
Hello, I'm Aditya Bardia. This is a 53-year-old female in good general health. She had a routine screening mammogram, which revealed a suspicious lesion in the lower quadrant of the left breast. It was BI-RADS 4. No family history of breast cancer, no palpable masses or palpable lymph nodes. So after the mammogram, she had an ultrasound, which revealed approximately 2 centimeter hypoechoic lesion, and there were no suspicious lymph nodes on the ultrasound. So then she underwent a lumpectomy, a left breast lumpectomy, along with sentinel lymph node biopsy. Surgical pathology revealed an invasive ductal carcinoma, 2.5 centimeter in size. The tumor was ER positive, PR negative, and HER2 positive. Grade 2, 1 out of 3 sentinel lymph nodes were positive for cancer with macrometastases, and the Ki-67 was 18%. So, to summarize, a 53-year-old with hormone receptor positive, HER2 negative early breast cancer, PT2, it's more than 2 centimeters in size, 1 out of 3 lymph nodes positive, so N1, M0 or a max Chi-67 of 18%. So the question is about adjuvant treatment. What adjuvant treatment would you consider for this patient? If we look at options, the options would be endocrine therapy, and that would have been the option, as of I would say, a year ago. But the landscape has changed now with the NATALEE study. So as a reminder, NATALEE study looked at ribociclib in combination with endocrine therapy for both premenopausal and postmenopausal hormone receptor positive breast cancer, and demonstrated that its addition of ribociclib would improve the or lower the risk of recurrence, so would improve IDFS. And NATALEE included patients with lymph node positive disease. So this patient would meet criteria for treatment with ribociclib based on the NATALEE study. So the correct answer at this time would be the combination of endocrine therapy and aromatase inhibitor with ribociclib for this patient with lymph node positive disease. Now, there's another CDK4/6 inhibitor that's approved, which is abemaciclib, but that has specific treatment criteria, and this patient would not meet the treatment criteria with abemaciclib. So that's for patients with tumor size more than 5 centimeters, or grade 3 disease, or Ki-67 more than 20%. If there are 1 to 3 positive lymph nodes. So this patient would not meet criteria for abemaciclib, but would meet criteria for treatment with ribociclib. So let's talk more about ribociclib, what to expect, what are the side effects to expect, and how to manage those. For this patient, I would start endocrine therapy plus ribociclib. Two important side effects to monitor. The first would be QTc prolongation. It's a small but known risk with ribociclib, particularly in the first 2 cycles. So we would get a baseline EKG on cycle 1, day 15, cycle 2, day 1, cycle 2, day 15, and then after that, as needed. The second one would be to monitor the liver enzymes. Those can increase with ribociclib in the first 6 cycles. So generally, we do monthly check for 6 cycles just to ensure that the liver enzymes are not increasing, for which sometimes you have to hold ribociclib. What if a patient has fatty liver disease or inflammatory bowel syndrome? In all of those conditions, ribociclib can be used It's just that you have to monitor the AEs carefully. So if someone is having diarrhea, treating the diarrhea. If a patient is having increase in liver enzymes, monitoring those liver enzymes. Other side effects to monitor would be, general nausea or fatigue and management of those AEs. With any CDK4/6 inhibitors, you do monitor the counts, particularly the neutrophil count, and if need be, reduce the dose of ribociclib. The recommended duration of ribociclib is 3 years based on the Natalie study, and the recommended dose is 400 milligrams. As a reminder, that's a lower dose than what's used in the metastatic setting. In metastatic setting, we use 600 milligrams of ribociclib, but in the adjuvant setting, in early breast cancer, it's 400 milligrams that's used. At the end of the day, we look at both risk benefits. We always think about over treatment. But for a patient with lymph node positive disease, with Natalie, we've seen improvement in IDFS, lower risk of recurrence that was maintained over time. We first saw the 3-year results, then the 4-year results, and the curves continue to separate. So I would consider ribociclib plus endocrine therapy for this patient. Please continue to case 2.
So let's talk about a case of a patient who sort of falls in the gray zone. And this is a patient with hormone receptor positive, HER2-negative disease, which would be viewed as sort of intermediate risk for recurrence. And the clinical characteristics that define her are that she's age 54 and postmenopausal. She does have a history of hypertension and hyperlipidemia. She's currently taking medications to address those two medical issues. She had a screening mammogram that showed a 3.1 centimeter asymmetry in the right lower breast, and followed that with a breast MRI that actually suggested it might be somewhat larger at 4 centimeters. The lymph nodes on the right axilla appeared normal. The patient undergoes a biopsy, which shows grade 2 infiltrating duct carcinoma. Tumors ER positive, 70%, PR positive, 90%, HER2 negative, 1 plus by IHC. She undergoes germline testing, which is negative for BRCA mutations, and she decides she wants breast conserving therapy and undergoes a lumpectomy. At the time of surgery, the pathology shows a 3.5 centimeter grade 2 infiltrating duct carcinoma with negative margins. 2 of 3 lymph nodes were positive, and the proliferation was reported as 19%. So pathologically, the patient is defined as PT2N1 disease. So when making a decision about how to optimize endocrine therapy in a given patient, we have to take into account what the eligibility criteria were for both Natalie and the Monarchy trial, and ensure that the patient meets those criteria. The other aspect of decision-making, of course, includes taking into account any other medical conditions the patient might have, and then, of course, what are the baseline comorbidities that patient has. And finally, we have to think about what are the expected predictable side effects that can be associated with a given CDK4/6 inhibitor. All that information has to be distilled in making the best decision for an individual patient. So if a patient has significant cardiovascular comorbidities, there are concerns with ribociclib, and as such, abemaciclib would be a better choice if the patient fits the Monarchy criteria. Similarly, if the patient has other gastrointestinal disorders, then abemaciclib, which is known to cause some GI symptoms, would not perhaps be your optimal choice, rather ribociclib would. And then when you start getting into older patients who might have hepatobiliary abnormalities or kidney impairment, your decisions also have to reflect those other problems. So in somebody with hepatobiliary comorbidities, abemaciclib would be a better choice, whereas if they have kidney impairment, ribociclib would be a better choice. So all of these nuances have to be taken into account when making a decision about an individual patient. Obviously, endocrine therapy is given for many years, but endocrine therapy, there's a fewer hoops, so to speak, to jump through than you may have to do with CDK4/6 inhibitor added on. And you have to think about whether or not the patient in front of you can tolerate 2 or 3 years of therapy and the nuances of the different ways that they're administered. Abemaciclib twice a day, nonstop, ribociclib 3 weeks on, 1 week off. So these are subtle things, but they have to be part of the equation in thinking how to optimize the therapy for an individual patient. When discussing the results of these interventions with the patient, above and beyond what I already discussed, you got to come down to what's the potential benefit. So the data from Monarchy depicted here shows that with follow-up now at 5 years, and as each year has gone by, the difference between the curves has not remained static. It's actually expanded, meaning that the improvement in outcome with abemaciclib is readily apparent. And now with the longest follow-up, we have almost 8% absolute improvement favoring the addition of abemaciclib. And the Natalie trial is trending exactly the same way. The follow-up is shorter. We have a 5% absolute improvement, and they're looking very much the same in terms of the conferred benefit that we see. So as we think about an individual patient that's sitting in front of us, there are many things we have to take into account. One is, what is the risk that that patient has for disease recurrence based on the profile of the patient at diagnosis, tumor size, nodal status, nuclear grade, proliferation, etc. We have to take into account the comorbidities that individual patient has, how compliant we think they might be with this kind of therapy. And of course, we have to think about the baseline toxicity that a patient might experience, any patient, with either ribociclib or abemaciclib. And we have to factor all those things in and come to a decision with the patient about what the best path forward is and how we manage those side effects in order to make the patient be more comfortable adhering and remaining compliant with therapy to realize the optimal benefit that comes from them. We want to make sure that rather than just improving the duration of a patient's life, we maintain the quality of their life during the period of time they're receiving therapy. And all of these things have to be discussed with the patient to come to the best decision for the individual patient in front of you. So please continue on to case 3, which is a hormone receptor positive HER2-negative patient at high risk for recurrence. Thank you.
It's a pleasure to be with everybody today. My name is Seth Wander. I'm a medical oncologist at Massachusetts General Hospital in Boston. And today we're going to review a case of a patient with hormone receptor positive, HER2-negative, high-risk early breast cancer. This patient is a 60-year-old woman, G2P2, who has a past medical history notable for type 2 diabetes, non-insulin dependent, and a remote prior stroke with no residual deficits. She also has hypertension. Current medications include metformin, losartan, and aspirin at 81 milligrams. In terms of her breast cancer oncologic history, she was diagnosed initially with a screening mammogram, which revealed a 45 millimeter asymmetry in the right breast. There was additional disease notable on baseline MRI with approximately 70 millimeters of mass and non-mass enhancement, as well as multiple abnormal appearing axillary lymph nodes that were palpable on exam. She had a biopsy of the right breast at 0800 with grade 3 invasive ductal carcinoma, estrogen receptor positive at 50 to 80% with moderate staining, progesterone receptor low at 10%, HER2 IHC was 2 plus with a FISH copy number of 3.5 and a ratio of 1.9, group 5 negative. She had a concurrent biopsy of the right axillary lymph node, which confirmed metastatic involvement. She had PET-CT staging studies at baseline that revealed FDG uptake in the right breast mass and axillary lymph nodes, but no evidence of distant metastatic disease. She had germline testing, which was negative for pathogenic variants, including BRCA. So here, given the fact that the patient had multi-node positive disease identified at baseline and clinically palpable, we decided to treat with preoperative neoadjuvant combination chemotherapy. She received dose-dense doxorubicin, cyclophosphamide, and paclitaxel, and she went on to proceed with a bilateral mastectomy per her preference, given the negative germline genomics. On her final pathology, she had 55 millimeters of residual disease with 30% cellularity, negative margins. The residual tumor was grade 3. There were 7 out of 15 regional lymph nodes involved via axillary nodal dissection, again with some treatment effect noted. So this was staged as a YP-T3N2 tumor. She received post-mastectomy radiation therapy, which was well tolerated. When she came to our clinic, we had extensive further discussions about optimal systemic therapy, and we reviewed some of the important new treatment options. We would like to pursue optimal adjuvant anti-estrogen therapy in this situation. We discussed the toxicity profile of both tamoxifen and the aromatase inhibitors and data related to the use of extended duration therapy for 5 to 10 years. Here, we plan to do 5 to 10 years of an aromatase inhibitor and would also likely consider bone supportive therapy, both in the presence of osteopenia as well as given some data suggesting small improvements in breast cancer recurrence. We also discussed emerging data related to the use of adjuvant CDK4/6 inhibitors. First, the monarchE study included higher risk patients. These patients had to have at least 4 positive lymph nodes, as in this case, or 1 to 3 lymph nodes with other high risk features, such as high tumor grade, large tumor size, or elevated Ki-67. The NATALEE study also included these high-risk multi-node positive patients, but did allow some patients with node-negative disease, stage 2, and higher risk features, or patients with N1 disease who would not have strictly met the monarchE inclusion criteria that we just reviewed. The monarchE study utilized 2 years of adjuvant abemaciclib, whereas the NATALEE study included 3 years of adjuvant ribociclib. The toxicity profiles of these 2 agents differ, and this is an important consideration in clinic when a patient like this comes and meets criteria for both drugs. Both of these drugs can cause fatigue and cytopenia, although the cytopenia rates are slightly higher with ribociclib than compared to abemaciclib. Ribociclib has rare rates of EKG changes with QTc prolongation, but these rates are even lower with the dose utilized in the adjuvant setting at 400 milligrams. Both of these drugs can rarely cause creatinine elevations or transaminitis and require careful lab monitoring. Abemaciclib can cause higher rates of GI toxicity, including diarrhea, and a subset of patients will require dose reduction and occasionally even discontinuation, although we become much better at handling and anticipating this in clinic, and the diarrhea rates tend to peak and improve after about 6 to 8 weeks of therapy. The other thing to consider is the length of follow-up we have for both of these studies. So for the monarchE study, we have more than 5 years of follow-up right now, and we see in the primary endpoint of invasive disease-free survival that the magnitude of benefit not only has remained constant, but has actually increased a little bit with each subsequent follow-up. Now, with more than 5 years of follow-up, we're seeing 7 to 8% improvement in IDFS rates, even while all patients on study have been off drug for quite some time. The data from the NATALEE study is similar, but somewhat less mature. Here we have about 4 years of follow-up with a 4 to 5% improvement in invasive disease-free survival. The overall survival data for both monarchE and NATALEE is not yet mature, and so we can't really draw conclusions about overall survival, only durable IDFS rates now over 4 to 5+ years for both studies. I think at this time, with a patient like this who's eligible for both drugs, it becomes a complex discussion in clinic, and it takes into account patient preferences in terms of 2 versus 3 years, the toxicity profile, medical comorbidities, including baseline liver issues, baseline cytopenias, baseline GI-related toxicity. And if all else is equal, many people at the moment might prefer to think about the monarchE abemaciclib data because we have a longer duration of follow-up off drug. But again, this is a highly personalized decision. And I think as the NATALEE data continues to mature and continues to look good, we may have both options, which would really be on semi-equal footing over the next few years if that holds true. If this patient had been BRCA positive in the current treatment landscape, we also would have had the opportunity to think about olaparib per the Olympia study. And this is an important option for high-risk patients with germline BRCA mutations. And here, again, you have significant improvements notable for these patients in terms of recurrence risk. We would not utilize the PARP inhibitor together with a CDK inhibitor given concurrent risk of toxicity, particularly with cytopenia. But I think many of us might choose to sequence these therapies, either start with the PARP inhibitor for a year and then move on to 2 to 3 years of the CDK inhibitor or vice versa. Unfortunately, we don't have any prospective data for this approach because folks in Olympia did not receive CDK4/6 inhibitors, and folks in Monarchy or Natalie did not receive prior PARP inhibitors based on the inclusion criteria and timing of treatment initiation. And so we have to use our best clinical judgment, think about the patient preferences, think about the tumor risk profile. But I think it would be something that would be very reasonable to consider in this particular situation. So with that, I'd like to thank you, and please continue on to the last segment of this activity where Dr. Gratishar will share his concluding thoughts.
Well, I hope you found the case discussions useful. Our goal in illustrating these different cases is to represent the different kinds of patients with early stage hormone receptor positive breast cancer. Based on data we now have available from a variety of trials, we know that we have nuance in how we make decisions for treating these patients. Some patients only require adjuvant endocrine therapy, whereas those with higher levels of risk of recurrence may require other additional therapies and targeted therapies added to their adjuvant endocrine therapy. We know that in higher risk patients, including some select patients with node-negative disease, the addition of a CD4/6 inhibitor to endocrine therapy improves outcome. Additionally, we should always remember that patients who harbor BRCA1 or 2 mutations may be candidates if their risk is sufficiently high for adjuvant PARP inhibitor therapy in the form of aliprib. How these therapies will be sequenced, again, leads to the whole goal of tailoring therapy for those patients who have the highest risk. So with that, I'll conclude, and I want to thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you.